College Dublin. The criteria for participant enrolment would that the participant would be over 18 years of age and that they would have one or more chronic disease. And I suppose the chronic diseases we looked at were those of respiratory nature, coronary obstructive pulmonary disease, COPD, chronic bronchitis, emphysema or asthma. Under the heart disease area, we looked at congestive heart failure and coronary artery disease. And then diabetics, and the participant could be diabetic type 1 or type 2. So I suppose, how did we go about recruiting patients into this service and identifying appropriate type patients? Clearduck has a long established history of healthcare provision in Ireland with out-of-hours GP services, telephone triage services and community intervention nursing teams. So I suppose we built on those existing relationships and meetings were scheduled in GP surgeries. So we met with GPs, we met their practice nurses, we met visiting clinicians into the surgeries. We also used, I suppose, our relationships. I utilised our relationships with the consultants and clinical nurse specialists in the hospital. Again, informational meetings were scheduled in the hospital. We attended the OPD departments, participated in ward rounds, in hospital ward rounds, and I suppose outlining what a project like SMILE could do to support the patients that they manage, both in the community as GPs and in the hospital environment as consultant and clinical nurse specialist. So I suppose we looked at that we would need approximately 500 referrals from our GP colleagues and consultant colleagues to then be able to take from that 500 about 120, 130 participants that would meet the stratification criteria for entering the programme. But within a week of carrying out informational sessions with GPs and consultants, the referrals started to come. And I suppose what we noted on those referrals were that the patients that had been identified by GPs and the consultants completely, in the vast majority of cases, met the criteria. So we very quickly reached our number of between 120 and 130 participants that we had planned to provide interventions, nurse support and deploy equipment to. So I suppose just to give you a breakdown, we had 155 referrals that were accepted. Out of that 155, 106 of these patients received technology, wearable health monitoring devices, and also received calls and continue to receive calls from our triage nurse. It was 30 of the referrals then were identified that would receive support calls and no technology. And I'll go into that a little bit later on under the COVID-19 section. And there was 19 then participants, unfortunately, that were not able to participate in the programme. And I suppose some of the reasons for that was deteriorating health, hospital admission, nursing home admission, or simply they didn't have the dexterity to be able to apply the monitoring devices. So anyway, we had 106 with equipment deployed. And I suppose that area, that time during our project implementation was one of the busiest times where our nurses were making outbound calls and giving further information to the participants and reassurance and understanding what the programme was about. And really, I suppose, gaining from them were they happy to participate and to remain in the programme. At that time also during those calls, the time for the visit from our field tech would take place. Just to say, on the team we have ICT, we have telephone triage nurses, we have nursing, we have nurses who carry out triage over the phone, and we have our field tech support. And the field tech support were those that visited the participants in their home, brought the equipment to them, educated them how to use the equipment. There was quite a number of pieces, and I'll go into that. And I suppose give them the knowledge to be able to use these pieces of technology. So as I said, the implementation involved the enrollment forms, consent forms, and we distributed questionnaires at the start of the project, and questionnaires will also be distributed near the end of the project. And I suppose those health questionnaires really are about measurement of comorbidity index, technology usage questionnaire, and we can do a comparison then with the questionnaire that was completed at the outset of the programme and nearing the end of the programme. And as I said, the field tech provided educational training on the devices as they deployed them to the participants. So I suppose just to talk a little bit about the wearable technology, the health monitoring devices that participants receive. And in this photograph, we have Barbara there as one of our telephone triage nurses and Jason there, one of our field support technicians. So the equipment that was distributed were pulse oximeters, blood pressure monitors, smartwatches, Samsung Galaxy tablets and blood glucose monitors for diabetics, and weighing scales then for heart failure patients. And these are all what we call iHealth. They're all Bluetooth monitoring devices that will relay the data onto the software program, which is called ProAct CabiSIMS, developed by Dundalk Institute of Technology and Trinity College Dublin. So what did the devices capture? The smartwatch, which was continuously worn, captured steps, distance, sleep quality, hours of sleep, restlessness. Blood pressure monitors, as self-explanatory, collected data on their blood pressure and their heart reading. Diabetics received the blood glucose monitor, and that measured their glucose levels. And we would expect that they would measure their glucose levels around mealtime each day. Pulse oximeter measured oxygen saturation levels, particularly important in our COPD patients or those with respiratory conditions. And we would ask for participants to measure this once or twice a day. So usually it was measured in the morning and again maybe in the evening before they went to bed. Then they had the option to self-report on their Samsung tablet where the data was being gathered on their mood on the day, how they felt down, they felt elated, lonely, if they had pain, and how their general condition was. And one of the questions in that also was their compliance to their medication. Okay, so I suppose just to talk a little bit about the participant condition types. 10% of our participants had heart failure, 30% were COPD, and 60% were diabetics, both type 1 and type 2. The service profile of our participants, the age range, 52 to 81, so quite a broad range there. And I suppose we have to think of this age group and this age category embracing technology, having their Samsung tablet, being able to read their monitor device readings, being able to interpret them, being able to connect to the data, to the internet, all of that. And our field tech support spent quite some time with each participant, educating them and reassuring them and giving them the confidence to be able to do this. The breakdown between male and female, with 63 females and 67 males. So I suppose just to talk a little bit about from the clinical end of things, early in the program, once we had established readings from participants, once they were up and running and they were able to take their blood pressure, blood glucose and various things, we would then work on setting thresholds. And I suppose we would have a baseline threshold for the norm, but then we would have maybe a COPD whose normal oxygen saturation might be 90%. And that's what they live with every day. This is what their consultant are happy that they maintain. So that would be the threshold for that patient. Not the 92% or 93%, it would be set at 90. So on a day-to-day basis, the nurse at the start of her shift in the morning, she'll read the vital signs, the range of vital signs for the patient that has had an alert. She will then, if necessary, make an outbound call to those patients and ascertain what's happening. She'll look at the overall general picture of health that's been presented to her, and she'll make a decision then whether to advise the patient to contact their GP and seek further medical attention, or whether maybe she's been able to establish what's been the cause of this. Has it been, maybe if they're diabetic and their blood sugar has been quite increased, maybe it's due to something in their diet that they have changed, and she can educate around that. But if there's an increase in pulse, an increase in blood sugar, maybe an increase in blood pressure, she may be looking at a scenario where there's a developing infection. So that's the early identification of or deterioration of a patient. Picking them up early, being managed in the community by their GP, and avoiding that acute situation where they become so unwell they actually need to be transferred to hospital. Not alone, I suppose, just monitoring of their vital signs is the only part of their health that's important. Health and well-being, their ability to meet and socialise and interact with people. What's their supports in their home? What's their hobbies? How can the nurse encourage them to do maybe a little bit of gardening? We have one participant who could no longer go out into her garden, and she was in fact to trip or fall, and she just found it quite difficult. So our triage nurse suggested to her, why not try a window box? So she has 3 window boxes with lettuce and onions and various things going. So it's given her back a little bit of an interest in life. And she waters it with a teapot because she's not able to carry a watering can. And she'd never thought about suggestions like this. So she's very proud of her little window box. And we've all had a little bit of her lettuce and garden has been coming to us. So I suppose one thing that stands out in this project is the integration between all the health service providers, because this category of patients, they have chronic disease, so they interlink quite frequently with a number of healthcare providers, and we all think we're doing the best for them, but sometimes there's not that linkage. But I suppose what we found with the SMILE project was the patient presented with their tablet, with all their readings, their blood sugar readings, their blood pressure, their steps, all of those. So whatever clinician they were seeing, they had an opportunity to show them, whether it be their clinic, their diabetic nurse specialist, or their consultant, cardiac consultant, and they could see the readings for the last 4 weeks. Not just the reading that arrived on that day in the OPD department. They could see what was, on certain days where they were quite stable and where maybe there was triggers to increase them. So other healthcare providers found it hugely beneficial. And the challenge for us was when they saw this working for their current cohort of patients, they wanted more patients to join the service. So some interim outcomes. And I suppose targets were set that achievable targets. Targets were set that 50% of participants will improve their self-management and medication compliance. We'd like to say all participants are engaging with the triage nurse. They're self-managing their care. Now, it didn't happen overnight. The first couple of weeks, they were learning, and there was a lot of anxiety about the equipment, and sometimes they forgot about their health. They were so worried about using the equipment. So we needed to turn that around. They needed to get confident with the equipment and their wearable devices, and they now needed to understand what the readings meant. They needed to understand what were the triggers to causing their blood sugar to rise, their oxygen saturation to drop, the signs and symptoms of infection, and I suppose self-managing their care. And to see that they were starting to do this 3-4 months into the project, you see a stabilisation of alerts, a reduction in alerts, a stabilisation in the readings, and a greater understanding by the participants of how to manage a situation that arises due to their healthcare. 90% of the patients who've been equipped with the monitoring technology are engaging on a daily basis or every second day. It's absolutely wonderful for us. 10% are engaging about once every 5 days. And some of our participants work. They're outside the home working, the younger category. So once a week, they'll check in with their vital signs, and they'll also receive phone calls from the triage nurse. All patients are currently compliant with their medication. The compliance with medication is a big challenge. For them to understand the effects and the side effects of their medication, not just stop taking their blood pressure medication when a headache develops and just saying, look, it's not working for me. Their blood pressure will continue to rise, and these are things that we saw in the early stages of the project. And our triage nurses will encourage that patient to go back to their GP and discuss the blood pressure and the effect it's having on them. And maybe there may be an alternative treatment, and that has worked very successfully. So another interim outcome targeted 20% increase in the stabilisation of patient condition among participants measured by their clinical symptoms and vital signs. We had a 92% of our patients stabilised in their condition. 20% reduction in the unscheduled care episodes among participants measured by a reduction in the number of visits to GPs and emergency department. And this was our third core criteria that we wish to meet. In all of our participants, because they've got chronic disease, will have scheduled visits to the hospital, to OPD, to their GP for bloods, assessments, various things. But it was the attendances outside these we needed to look at. How could we work at reducing them? Reducing the amount of time that chronic disease patients spent away from their homes and in the hospital environment, where there was always the risk of secondary infections and long duration admissions. 35.5% of our patients have a documented reduction in unscheduled care episodes and have reduced their visits to emergency department. And just even some examples, P05 for privacy and confidentiality, we assign a P number to each of our participants. So P05 had 24 courses of antibiotics in 2017. So every month they had 2 courses of antibiotics. In 2020, none prescribed in 2020 since joining the SMILE programme. And as I said, these were about 4 or 5 months into the programme. No hospital admissions this year, no unscheduled attendance to GPs since the start of the programme. It's a huge, hugely positive for that patient. P30 had an admission rate of 3 to 4 times a year for the past number of years. And 3 to 4 doesn't seem that huge, but those 3 to 4 times a year actually often led to a 4 and 5 week stay in the hospital. So that P30 has had no admissions since the start of the SMILE programme. I suppose COVID-19, whether it be personally or in our work life, everybody has felt the impact of COVID-19 and continues to do so. When we started our project, we started off with 2 cohorts of patients, one that would receive technology and nursing support, and the other that would receive only the questionnaire and no technology or no nursing support. Both would receive the questionnaire at the beginning and the end of the project to compare their progress. 136 patients are now receiving an intervention from the SMILE project. We started out in the outset of the project where I spoke about 30 participants that were receiving telephone nurse support only. This group were identified as, during the COVID period, it would be of benefit to them to receive a phone call from a nurse. They had chronic diseases. They were 30 participants that, for a number of reasons, were unable to connect with our wearable technology. Some didn't have Wi-Fi, various things, but they were the group that we would measure against the group that had technology. So we decided during COVID, when many of the healthcare visitors and health providers that they would normally have come into their home were now unable to do so, that these 30 participants would receive telephone support from our triage nurses. And it was hugely successful. They were nervous, they were cocooning, they had lost contact with a lot of the social interaction they would normally have, whether their religious services on a Sunday or their daycare services. They now were cocooning at home and could really only walk to their gate, and for some even that wasn't possible. Some were living alone, they were quite lonely. So I suppose this phone call from the nurse once a month, or more frequently if the nurse determined that it was required more frequently, to check in, how are things going, give them some advice on COVID-19 and how they can avoid the risk of infection, supporting them, motivating them, encouraging them, and I suppose encouraging them to seek health care when it was needed, because that was a huge challenge for us in Ireland, the number of patients that did not seek health care during the earlier stages of the pandemic and lockdown. So I suppose these patients, along with the patients that had technology and nursing support, they received information and knowledge that empowered them to self-manage their health. And they learned about their conditions and how to manage them. Just quickly then, some further patient stories. P75, this lady has constantly taken on board the advice from the SMILE nursing team, and her overall health has benefited. She's commenced on blood pressure medication and she's feeling much better. She enjoys interaction with the nursing team as she's a carer for her husband. And she's found cocooning during lockdown difficult and lonely. So having the chat with the triage nurse means a lot to her. It breaks the monotony of her day. P21, this gentleman, he lost 4 stone since starting the programme. He's stopped drinking alcohol. He's joined a weight reduction programme and is on the cusp of reversal of his type 2 diabetes. His GP has stopped all of his oral hypoglycemics, and following his upcoming blood test, HB1AC blood test, his GP hopes to be stopping his insulin, which is huge for this patient. He's got a young son and he's very eager to be able to participate in his growing up and being able to run around with him and really be able to keep up with his young son. He would describe it as, he attributes what's happened through the SMILE programme as saving his life. We have another P83. She's delighted to be selected, and she's writing a letter to her GP to thank her GP for putting her forward for part of the programme. Thank you very much. If there's time, I'm very happy to take questions.